Thank you, Dr. Shaha. That was wonderful. We'll come to some questions shortly. But before that, this is my opportunity to introduce our second speaker. Joining us from Lima, Peru is Dr. Magali Blas. Dr. Blas is the director of Mamas del Rio, or Mothers of the River, a social innovation program that aims to improve maternal and newborn health in rural and remote areas of the Peruvian and Colombian Amazon regions. She does this through community health workers empowered with technology. Dr. Blas studied medicine at Cayetano Heredia University in Peru and finished her MPH and PhD in epidemiology at the University of Washington in Seattle. She's also an associate professor at the Cayetano Heredia School of Public Health and an affiliate associate professor at the University of Washington in the Department of Global Health. I know that Dr. Blas has been working with the Northern Pacific Global Health Consortium, which is a Fogarty-funded consortium. It's my privilege today to invite Dr. Blas for this next talk. Dr. Blas.
Buenas tardes con todos. Thanks, Shaylee, for the invitation, and good afternoon to all of you. It is actually a pleasure to speak at the Cui Peterson Global Health Lecture about the spillover effects of the COVID pandemic. And I agree with the previous speaker. This pandemic has created one of the biggest economic, social, political, and health crises of the last century. In fact, Peru has been the country with the highest COVID death rate in the world. We have had 500 deaths per 100,000 people. And COVID has also created spillover effects, among other conditions. So far in Peru, we have seen a 46% increase in maternal mortality, as well as an increase in mortality due to other conditions. So today, I will talk about the impact of the pandemic on women and families of our program called Mamas del Rio, or Mothers of the River in English. Then I will talk how our maternal and neonatal program had to adapt to fight COVID, and how important was to have a community health worker-based program to continue supporting maternal and newborn health when almost all the health centers in our area cease their operations. So to give you more context, I will explain you what is Mamas del Rio, or Mothers of the River. So Mamas del Rio is a maternal and neonatal health program in the area of implementation science that aims to improve essential newborn care practices and neonatal healthcare seeking through educational home visits by community health workers, like the one you see in the picture, to pregnant women and newborns in remote rural areas in the Peruvian and the Colombian Amazon. These communities have been traditionally neglected from our healthcare structures. In Mamas del Rio, the core of our intervention, I will say the heart of our program, is the training of community health workers so that they can conduct home visits to pregnant women and newborns empowered with tablets that have an application that helps them deliver health content in the form of pictures and videos co-created with the community. And they also use the tablet to gather data, like for example, the place where women want to deliver, the home or the health center, the history of prenatal controls, and newborn weight. The intervention of community health workers is supported by the training of traditional birth attendants on how to perform a clean delivery at home. And here it is important to mention that according to our research, in our settings, 80% of women deliver at home, and around 50% of them do it with a traditional birth attendant. So this is the reason why we train them. The other supportive intervention that we do is the training of healthcare personnel on essential newborn care practices and the sensitization of communities at 3 levels, with the leader of every community, with all the community, and with women of childbearing age. All of this is supported by a supervision system in which a nurse technician conducts a mixture of in-person, and also she conducts remote visits by phone to provide monthly support to our community health workers. So in summary, these are the components of Mamas del Rio. We have a community component that includes the training of community health workers, traditional birth attendants, and we do community sensitization. A health facility component where we train healthcare personnel, all supported by a supervision system. So we operate in 114 indigenous communities that are located along major rivers. we first started in 2017 to work along the rivers Marañón, Ucayali, and Amazonas in the districts of Nauta, Parinari, and Saquena. This was thanks to the support of Grand Challenges Canada and the Peruvian Council of Science and Technology. And this year, we expanded our operations to the Putumayo River, which is this, in Peru and Colombia. So we're working in Soplín Vargas and El Estrecho in Peru, and in Puerto Leguízamo, which is here, and San Rafael here in Colombia. This was thanks to the support of the Binational Plan Peru-Colombia and the Inter-American Development Bank. The areas where we operate are considered in extreme poverty and are dispersed along 750 kilometers of the Amazon River. Now, the access of our communities to the health centers is difficult and costly. Families have to navigate up to 2 hours by river to get to the health center in a trip that is expensive due to the cost of gasoline and dangerous because the transportation takes place in these pequepeques, which are wooden canoes that can easily flip over. Our intervention area includes 18 health posts and 3 health centers. Supposedly, all health facilities are prepared to provide routine antenatal and postnatal care, emergency, and imminent birth care. However, half of our health posts are only staffed by a nurse technician, are poorly equipped, and often lack basic infrastructure such as running water, electricity, or sanitation. And actually, the nearest hospital is located in Iquitos City, the capital of Loreto. And to arrive to this hospital, you have to take a 12-hour boat travel to Nauta, which is the regional town, and then a 2-hour drive to Iquitos. So all of this was before COVID. So in Mamás de Río, we actually were in our 2nd year of operations. I remember it was March 15 of the last year, 2020, 9 days after the first patient with COVID was diagnosed in Peru, when our president declared a national emergency that included immediate closure of all borders, home isolation enforced by the police and the military, and prohibition of non-essential business and domestic travel. There was also a night curfew and school closures. Actually, our team was about to travel from Lima, the capital of Peru, to Iquitos when the airports were shut down and the access to the rivers were closed. So when this happened, we immediately thought on the effect of the pandemic on the families in our program, how we could help to fight COVID while continue supporting maternal and newborn health, and how we can contribute to the scientific literature on the response of indigenous communities to the pandemic, all while fighting COVID within our own team and families. In fact, Iquitos was one of the cities with the highest COVID prevalence in the world. So we had to think fast and we had to adapt. The first barrier we found was that because of the lockdown, we could not do in-person visits to the communities anymore. However, because of the supervision system we established, we had a directory of the communities with phone contacts. So we implemented the televisits that were phone calls in which the supervisor talked with community leaders, community health workers, and health staff, maintaining in this way their routine supervision and monitoring activities. These televisits allow us to train the communities on how to prevent coronavirus and what measures the communities can implement when having a suspected case. These televisits also allow us to collect information on measures that were being taken by the communities against COVID, information on the availability of medical care and the impact of COVID on the activities of the community health workers. In general, we found that the communities we contacted had measures in place to respond to COVID, although there were considerable variations among them. We also found that some of the recommendations made by the central government were either not applicable or not adopted by the indigenous communities. For example, home isolation as mandated by our government was not possible because 3/4 of households in the communities source their water from the river or public wells, and the primary activities, which are hunting and farming, require them to leave the house multiple times a day. So strict home isolation was not feasible. Now, regarding the recommendation made of a 14-day quarantine for any person entering the community, we found that almost all communities banned the entry of foreigners. However, most communities tolerated residents to travel to larger towns to purchase supplies, sell products, or claim social support. And in these cases, the communities didn't do home quarantine. This is the reason actually why we believe that returning villagers were most likely the entry corridor for COVID to rural communities, especially after visiting crowded urban markets that were infection hotspots in Peru. Now, regarding the provision of routine maternal and neonatal health care, we found a substantial disruption in services. Only 1 in 7 health facilities continue to offer antenatal and postnatal care, and the ones who offer care attended only women at their communities because of the entry bans. And these health staff suspended services due to orders by the regional health authority in some cases, and in other cases suspended services on their own account to protect themselves. And this was in part due to the absence of COVID test kits and insufficient stock of personal protective equipment. The collection of all this data that I am mentioning was possible because as part of the mixed methods study evaluation of Mamás del Río we're conducting, that actually we're going to finalize this year, we had one sub-study that included the collection and analysis of written supervisor reports. And these allow us to systematically collect and analyze the data. We shared this analysis with decision makers at the Regional Health Direction of Loreto, and later we published these findings on BMG. And in this paper, we provide some recommendations like the promoting of, for example, the importance of promoting mask use, especially in the context of rural communities where strict home and community isolation is not feasible. For this, the government in the future should supply the communities externally. In fact, we as a program did both of them in our areas of operation. Also, if we want to make strict community isolation feasible, the government should deliver regular supplies to discourage the communities to travel to urban areas. And also the government should establish in rural areas points to claim cash incentives from social programs to avoid exposing risk groups like happened in Peru. So as a program, we conducted 6 actions to fight COVID and continue promoting maternal and newborn health. First, we applied to grants from Grand Challenges Canada and the Inter-American Development Bank, got the funding and shipped prevention materials to 16,000 people in 5 Amazonian rivers. This material included posters, flyers, audios, and videos about personal and community COVID prevention. We also shipped supplies such as soap and reusable masks for every member in the communities. We also sent instructions in paper and video on how to create this face mask, and later we were able to travel. And when we were able to travel, we did the workshops. We also established a COVID protocol in the daily activities of community health workers that included instructions on how to protect themselves and the families they visit from COVID, and what actions to perform in case of finding a suspected case. All of this motivated the community health workers to continue their visits during the pandemic, which was reflected, and we are happy about this, in the distribution of pregnancy tests and clean birth kits during home visits. We are currently doing the final evaluation of our program, and we plan to do an analysis on the contribution of the work of community health workers and traditional birth attendants during the pandemic. The third action we did was to promote a community-based plan in response to COVID, so community health workers can identify possible COVID cases, isolate these cases, and refer them to the nearest health center if needed. We also prepared a distance video-based training that included 9 sessions and 39 videos that could be deployed on tablets and replace or supplement in-person training. We got funding from the Peruvian Council of Science and Technology to conduct a pilot in Loreto to develop an active vigilance system for COVID-19 based on community health workers empowered with tablets. So in this case, the community health workers didn't look for pregnant women, but looked for patients with symptoms or complications due to COVID and reported these patients to the health system. Now, when the vaccines arrived, which were very late in Peru, we also trained the community health workers on the importance of the COVID-19 vaccine. So now community health workers have become advocates for COVID-19 vaccination, organizing their communities before the arrival of the vaccines, being an example for their communities by getting vaccinated first, and coordinating the arrival of more vaccines if needed. So, to summarize all the valuable lessons we learned during COVID. First, our program was able to adapt and apply alternative tools like remote supervision and monitoring activities to continue our operation. Second, during a time where in-person data collection was not feasible, we gathered information remotely through a pre-existing supervision system that was used to inform regional authorities, understand communities' needs, and prepare an immediate delivery of educational materials and supplies for COVID-19 prevention to communities. Thanks to this system that was in place, we were able to train community health workers on how to prevent COVID, and the community health workers were trained and equipped to continue their home visits while minimizing COVID-19 infection risk. Finally, I want to highlight that the most valuable lesson we learned was that having a community health worker-based program helped women and newborns to continue receiving health promotion and disease prevention when the health facilities cease their operation in our area. Also, this community health worker system provided a unique opportunity to implement community-based prevention and containment plans for COVID-19. Currently, we're advocating for the inclusion of community health workers in the Peruvian health system, especially for remote and rural areas, and we're working to insert Mamás de Río as a public policy in Peru. Our healthcare system has become very rigid and in many ways not very responsive to vulnerable sections of society. COVID-19 has exposed this. So it is important to look at innovative models of taking healthcare to communities and strive to involve communities in their own care. We believe that Mamás de Río is a model that's that. So thank you very much for your attention.
Thank you, Dr. Blas. That was wonderful. I'm going to open this up for questions, and I would encourage our audience members to type the questions in the Q&A section, and I'll moderate the questions as they come. I'm going to get us started with a question from Dr. Peterson. Dr. Shaha, one of the things that we talk about is that we have a pandemic of COVID-19 and a pandemic of disinformation. How much has social media played a role in either sending information or disinformation in Bangladesh?
Thank you, Shaili and Peterson, for the question. Extremely important question. We perhaps it's a joke in many countries that it's not only SARS-CoV-2 that went viral, many things went viral during this pandemic. Social media played a huge, huge role. So to begin with, the way we immediately acted, for example, our initial action was really not based on always our judgment as scientists, but oftentimes, based on what's going on in media. I remember, at the beginning of March, walking into the lab every day and everybody discussing what's going on in Italy, because on Facebook, people were all they were seeing are, patients, older patients in Italy dying with balloons like things around their heads. So the fear that we all started our lives with in March every morning came from social media. And then with time, everything evolved. There were many good things, there were many bad things. And misinformation was a very, very big problem, like stigmatizing definitely often started over there. But at the same time, for example, where can you get tested? What are the hospitals with available ICU beds? All of this information was also very available on social media. So social media played a big role. And then as the pandemic evolved, every journalist in Bangladesh, I think, became a science reporter, which was very, very interesting to see. Our journalists knew a lot more about variants, I think, than we did. And oftentimes there would be like, story of one variant in one country, and someone maybe from that country came into Bangladesh, and there would be reports of how that variant has suddenly spread in Bangladesh. So all of those things we had to deal with, that were, a part of the misinformation. But at the same time, what we did see personally is this interest in science. Interest in understanding what an RNA virus is. The RNA viruses were never discussed in social media before, right? But I remember the first time we sequenced SARS-CoV-2. For us, we had sequenced viruses before. So we sequenced SARS-CoV-2, we uploaded on GISAID. I think I uploaded on GISAID and went to bed. In the morning, they were like 20, 30 missed calls from journalists because a sequence was uploaded on GISAID, and I didn't know that could be a thing. It was all over Facebook that a Bangladeshi virus was sequenced. All journalists were talking about it. We were on TV for like the next few days. So that is where social media also played a role. And to date, I get calls from many people on who saw us on social media saying, I want to become a microbiologist and sequence viruses. So that's the other extreme of it. So we saw many things during this pandemic. It was really a crash course.
Thank you for that. And I should ask this follow-up. You and I have had this conversation about how reactive Bangladesh had to be because of news from outside the country. Could you elaborate on that a little more, please?
Sure, Shaili, thanks. So as we reflect back as a group at CHRF on what happened in the last 2 years and how we reacted to the pandemic, we realized that we didn't react the way we normally do to outbreaks and epidemics. As I mentioned during my talk, that dealing with outbreaks is nothing new in Bangladesh. Every year, we deal, for example, with the dengue outbreak. In 2019, just the year before COVID hit, 2019 was the worst year in history for dengue. Our hospital beds, every day we were seeing 200-300 beds being filled up with just dengue patients. We were working day and night, but that in no way meant that we forgot every other disease. That in no way meant that we only focused on dengue. We did everything else at the same time. We increased or expanded our focus to dengue, because this is something we deal with every year. This is kind of like, Bangladeshi disease has become a Bangladeshi disease for us. But when it was COVID-19, it was new. All the information was coming from the outside, right? I remember looking at modeling papers after papers, epidemiological modeling of what is going to happen in South Asia. And of course, after the first cases were detected, all models said that millions of people will die in Bangladesh. And remember, all of these models were actually not conducted by Bangladeshi scientists, so the assumptions were probably not correct. But we believed them because we were seeing videos from Italy and we thought the same thing is going to happen over here. So all of that, the data, the pictures, social media made us believe that this is the end of the world and we need to drop everything else and just focus on COVID-19. So I think we acted very differently, and as an organization, we feel a little guilty too, because over the last couple of decades, we have advocated for non-vertical surveillance. We have said that, you cannot just focus on one pathogen, because when a child comes into a hospital, a child doesn't come into a hospital with RSV pneumonia or pneumococcal pneumonia. They come in with pneumonia. They come with meningitis. So everybody should get the same attention, and we should try to understand all causes of diseases. So somehow, I guess the entire focus, the outside media, the recommendations from international committees and organizations definitely biased a little bit our view. Thanks.
Thank you. I appreciate particularly the nod to moving away from a single disease approach, right? Community-based approach strongly recommends moving away from a single disease approach. Thank you for that. Dr. Blas, a couple of questions for you. One is, your community health worker program has been attached strongly to technology. Have you had to invest a lot in technology? And was there infrastructure already present for you to ongoing support of the community health workers?
Well, I think technology has been key for us. I mean, to give the power of technology to community health workers that live in remote and rural areas, we're proving that it has been very useful, because then we can have information that the Ministry of Health of Peru doesn't have, because they don't know if a child has been born in their home or even in a health post in rural areas. They don't have that information. Or for example, they don't know if a 15-year-old woman wants to deliver at home or not. No, they don't have this information, and this for us has been useful also to monitor the activities of community health workers. So for example, if we see a 10-minute visit, that should be a 45-minute visit of a community health workers, we know that something is happening. So in general, I want to emphasize the importance of technology for us. We have some infrastructure in the sense of antennas. The Peruvian government made actually a Vietnamese company called Vitel. They agreed that before entering into the Peruvian market, they were going to go first to rural areas in the Amazon. So we have 4G connection. I don't have water, electricity, or sanitation, but I can have a video conference with my daughters in the Amazon River. So that existed in several of our areas, not in every area. But we have to invest in the tablets, on maintaining those tablets. Remember, it's super hot, no? Very humid conditions, raining. So we have to rechange those tablets along the way. We work with ComCare, which is our application. And of course, we have created the videos with the communities, etc. But we have to invest in this system, yes. And I want to add something regarding the last question of misinformation. Yes. So to fight misinformation in urban areas, well, you can do it. You see the television, etc. But in rural areas, once something that is wrong enters, then it stays there, and it's difficult to take it out. So in the training of the community health workers, where I participated 2 months ago, we had to deal with this misinformation of the vaccines, because there was, for example, this information in Peru that the Chinese vaccines were not as good as the US vaccines, so people didn't want to get vaccinated with Sinopharm. So we had to train them on the importance of getting vaccinated with the vaccines that you have. So I just want to mention that for the media, they have to be very careful when showing news that are not real and not trusted.
That's fascinating. It's how in an urban area, maybe the sources of information are many, but in rural areas, maybe the sources of information are a few, but if the information comes in, it gets rooted. That's a fascinating observation there. I have a follow-up question, a couple of follow-up questions on the community health worker aspect. You have talked about the importance of community health worker in your work, and community health workers have been used around the world. Do you see the community health worker program being used beyond maternal and child health, other diseases, other conditions? And if so,
yeah.
What would be the ideal characteristics of a good community health worker?
Yes, of course, they are already being used for other diseases. In Peru, they fight malaria, dengue, leptospira, anemia in children, and also in other parts of the world. Community health workers are very important. In fact, five cluster randomized controlled trials in Africa and Asia have shown a 25% reduction in neonatal mortality by home visits by community health workers. But of course, this is depending on the environment, on the supervision system that you have. So yes, there is a lot of areas of impact of community health workers. However, they are underutilized. Currently, what we need is to make them part of the official health system, at least in Peru. I can talk in Peru, which they are not. So the Ministry of Health, what they do is when they have funding, they train community health workers for something and then they leave them. And maybe if they have funding in 6 months, they do a retraining, but there is not supervision at all. There is not, for example, a training on consistent messages that they have to do in specific points of time, for example, in the pregnancy that we do, and that the tablets help them to do it. So they know what message to do in the first visit, in the second, in the third, in the fourth, what actions, what materials they have to show, what videos they have to show to the pregnant woman. So there is a lackness of this. And what we need is to insert the community health workers in the health system. If this has been difficult, we have been fighting with this for the last 2 years. So I don't know if we will make them. Hopefully, the recommendations of WHO and other organizations are that they should be part of the health system. They should receive a payment, and there are several recommendations on what are the characteristics of community health workers in terms of education, in terms of, for example, having a ladder where they can grow, etc.
Thank you for that. Appreciate that. Dr. Shaha, I'm coming back to this point of your identity as an organization. And I was particularly impressed on how you reflected on moving away from the identity because of COVID, right? Because COVID sort of swamped your work and your attention was taken away. From your viewpoint, how do you see this evolving? Because if we can look at predictions, COVID-19 is not going to be the next only pandemic we're going to face. We're going to face others that come our way. So what do you think are the lessons you would learn, take from this as we tackle the next few epidemics and challenges?
The first lesson I think I have learned is that we don't learn from history. So, we try to, discuss everything that we have learned as an organization moving forward. But I don't really know how we will really act in the face of another epidemic or pandemic. Having said that, I think there are some infrastructural changes that have come about because of COVID-19. And that does not only, it's not only confined to our laboratory. I think in Bangladesh or overall in low middle income countries. And I think something that will be different going forward is the way we conduct testing, for example. We conduct genomic sequencing for communicable diseases. So for the longest time, we had this idea that, things like genome sequencing had to be done outside, where we shipped most of our samples outside. But during this pandemic, what we learned is there is a possibility that flights will stop, which we had never seen before. And there are times when even high-income countries can have diseases that can make them busy. So they will not be interested in the pathogens that are in low-income countries. So I think that is a huge lesson that we learned, and we have broken that barrier, right? There are constantly sequencing being done in many low and middle-income countries. There is qPCR testing being done. There are hundreds of labs in each country. I think if we can figure out how we maintain this infrastructure, how we maintain the capacity, because it's not only equipment capacity. We have trained hundreds and thousands of people on using these machines. right? Especially the PCR machines for diagnostic. How do we ensure that as cases dwindle over the next few years, hopefully, these machines do not gather dust, right? We continue using them and we do not go back to our previous cycle. So this is definitely one lesson that I keep on talking about, and I make the comparison with dengue. If we look at the next strain build of SARS-CoV-2 from Bangladesh and compared to that dengue, we have sequenced, I think there was a typo in my slide, but we have sequenced over 3,000, let's say, SARS-CoV-2 genomes compared to just a handful, perhaps like 25 genomes of dengue have been sequenced in Bangladesh. So how do we change that? Because dengue is a much bigger problem actually for our community than SARS-CoV-2 at the moment. But after all of that, I think, Shaili, we have to come back to how we conduct surveillance. What does surveillance mean? Right? Surveillance is the cornerstone of stopping outbreaks in their tracks. How do we forecast diseases? We have to move away from this pathogen-specific focus. We have to build surveillance systems that are comprehensive, that are not looking at just one pathogen at a time, because it's a waste of time, it's a waste of resources, and it defeats the purpose of surveillance. So I think that is something we really need to take away from here. And my worry is COVID taught us how important surveillance is, how important it is to detect outbreaks in their tracks, but it is also at the same time taking away from all the surveillance that were in place. So we have to find a balance somewhere and set up surveillance programs. Like I think Magli gave such a great example of how community surveillance can work, and that has to be the model. And one model is not going to fit all. Every country is different. Every community has different diseases. It's the communities, local communities, who have to decide what are the surveillances that we should roll out and what are the data we should gather and how we use that data. Thank you.
Dr. Shah, I really appreciate your mentioning that. I think we have had a tendency to look at vertical planning too much without taking into consideration the local necessities, right? So I appreciate you bringing that. I'm going to post this next question to Dr. Blas. Similar to what Dr. Saha mentioned, going from a model that looks at surveillance for all diseases rather than a single disease approach. In your program, have you had to change from a traditional model of delivering maternal and child health, particularly with the potential of mental health issues? We've heard stories of domestic violence increasing amongst communities, and the unfortunate byproducts of isolation and things like that have caused more problems. So Dr. Blas, have you had to look at your program to alter protocols or alter delivery of care?
Well, thank you for your question. Actually, we are doing an evaluation of Mamás de Rio. So I want to mention before answering your question that we have a protocol uploaded of the intervention in the London School of Hygiene and Tropical Medicine, with whom we're working for the evaluation of this program. So we could not depart too much, no? So in paper. Right. Then COVID hit, and we no longer were able to follow the protocol as it's specified. Yes, we have found a lot of violence against women and children, primarily. And one of the biggest issues that we're facing also is the lack of family planning and the huge percentage of adolescent pregnancy. So we are working towards that. Actually, thanks to the Fogarty Fellowship, we have 2 students coming to assess those issues. Family planning and adolescent pregnancy is huge, no? It's a new program itself. It's complicated since the point that people in our communities don't recognize adolescent pregnancy as a problem. So it's very complex. But yes, to those issues, and also the problem of violence against women and children, they have come up in our focus groups and in our interviews, and it's difficult to access help in rural areas. And this is one of the ways that we are going to follow. No, in urban areas, you can go to the police, you can report it to the Ministry of Women in Peru, but where do you go in rural areas? No, where can you see help? So we are, one, assessing the impact of violence in women and children, and second, we are going to try to create a path of what communities can do if they found these problems. Many times they think that there is a family issue, no? So if they see someone beating a woman, they say, okay, it's a marital problem. But how can we change this? Yes, this aside, we have also the other infectious diseases that we're not dealing as a project, but the Regional Health Direction of Loreto do it with like malaria and dengue. We have a huge epidemic while we were having COVID also.
Here is it's not strictly a follow-up, but it's an interesting observation from my point. You are working in a very remote, very shifting landscape, literally, in the Amazonas region in Peru and Colombia. I know how difficult it is to work in one district or one state or one country. So tell me a little bit about working across boundaries in two countries, which has not always had a good relationship between them.
Actually, we have a good relationship with Colombia, not with other countries,
okay.
but with Colombia, yes. Although we had a war some decades ago. However, so for us, it has been great as a program to train people in the Ministry of Health in Colombia and the Foundation Etnolano and Isegoría to implement what is called Mamás de la Frontera. That's the name of our project in the border, not like Mothers of the Border. That's the meaning of Mamás de la Frontera. The system has been adapted. However, since we face similar issues like high percentage of deliveries at home, lack of access to healthcare facilities that are not prepared, it's very suitable for a rural area in the Amazon. But we had to adapt because they have a different system. They have private insurance, even in remote areas. So also, for example, they allow abortion. So we had some changes, no? So for example, we, in Peru, still abortion is not allowed for women. So since the first visit, we asked and we talked with them about what is her plan for the delivery. They want to deliver at home or they want to deliver at a health center. However, in Colombia, this has to be moved to the second visit because in the first visit, you still don't know if you are going to continue your pregnancy, which I think should be a right for every woman. Mm-hmm. So there has been some changes, but in general, the program has maintained their core. And it has been great to work with them. We want to thank also all the funders who allowed to do that. And this was funded by the government and the Inter-American Development Bank in a pilot, and we hope that this pilot continue. One of the good things, for example, that I want to highlight that did Colombia is that they decided to train only female community health workers. Mm-hmm. And we are going to do the final evaluation of this program, and we are going to see this important lesson that I think we also need to learn, how to empower women by training only female community health workers.
Thank you for that. This is wonderful. I'm always thrilled when one program spreads, and particularly when it spreads across borders. So I appreciate that. I'm going to ask you folks to reflect on this a little bit. If we were to ask, what is one positive that you've learned from the COVID-19 pandemic? What would that be? Dr. Shaha, I'm going to start with you there.
That any country can fight a crisis independently, no matter where that country is located, is definitely something I have learned, and I think our country has learned. When we had to deal with COVID-19, realizing that we are completely on our own and we didn't have the support like we say support, collaborators, whatever we call our friends in the global north. When we didn't have them, we were scared at the beginning, but I think we did well. And that's definitely a positive lesson that I want to take forward. I want my organization to take forward, that when it is our problem, when we understand the context, we can definitely figure out how to solve the problem.
I like that spirit. There is a strong sense of resilience inbuilt in that words. Thank you for that. Dr. Blas, how about you?
Well, actually, what I have learned is the importance of adaptation. Our program had to adapt. We were a maternal and newborn health program. We were measuring the effect of our program with a protocol that we built, and we had to adapt fast to continue supporting maternal and newborn health, but also to fight COVID. Mm-hmm. And also what struck me a lot was the resilience of the communities where we work. No, it's incredible how they adapted. So they had to survive, but they are used to hunt and farm, so they have food, no, that they can use. They didn't want to go to the health post, and they rely on their plants. So that was one of the things that we have to work with, especially in cases where there was a lot of symptoms and the patients were not doing good. But I mean, the importance of resilience and this sense of community that they have, no? For us, I mean, in my home is 5 people, no? But for them, a community of 500 people is like a home. So I have learned a lot from them.
I appreciate both of you bringing resilience as an important factor. That's sometimes so neglected and forgotten, and sometimes very difficult to measure, right? It's, if I were to say, what is the resilience quotient of your community? You're like, I don't know what that means. But it's amazing that it's such a strong characteristic that both of you reflected on. I thank you for that. One technical question for Dr. Shaha. What was the primary transmission route for the 1-day-old who tested positive?
Okay, very good question. So something, a little bit of background over here. The hospital that we work with is a tertiary level hospital only for babies, only for children. So children are not born in this hospital. They're usually born at a different place. And if they're sick, they're brought to this hospital. The age that I showed in my graphs is the age at admission. And it's possible that they did not get tested the same day, perhaps the next day or the day after, within 48 hours of admission. To answer against this backdrop, I'm going to answer that question. What we did is we had this question too, because we kept on testing again and again this neonates, because we were like, this is so hard to believe that such young children are testing positive. So not only we tested them, we even sequenced the viruses to ensure that we were actually getting full viruses. And then because the mothers were with them, or the primary caregiver, sometimes it's a grandmother, we also tested them to see if they were positive also. And in most cases, the primary caregiver was also positive. From literature, we know that if the child is born in a very clean environment, maintaining all the safety protocols, even if the mother is positive, the child doesn't test positive. So there's very little chance of vertical transfer. So what we think happens is basically close contact after birth, where the child is exposed to the virus. Again, we don't know if the virus is causing severe disease in all of these neonates, probably not, but they are exposed, and there's definitely, a carriage that we are picking up during testing. So again, we think in summary that it is close contact with the caregiver who is positive for SARS-CoV-2.
Wonderful. I'm going to ask a hypothetical here. Let's say we have a genie from a very large foundation who appropriately are impressed by the two of you, and they want to give you a whole lot of money. What do you want to use it for? Dr. Shaha, I'm going to start you with that question.
Do you actually have a genie?
No, I wish I did, but.
Oh, damn it. Okay. I mean, there are so many things that we can use it for, right? If I am less selfish, then I will say that I want to use it for building the most amazing surveillance program. A surveillance program that is not only looking at all diseases, but also linking all of the diseases to next generation pathogen genomics, so that there is clinical surveillance, there is genomic epidemiology surveillance, they are linked, and we have real-time data of how pathogens are circulating in the country, trends, etc. And from the genomic data, we can design the next generation of vaccines, treatment, etc. So if I am, thinking of the entire country and all the diseases, that would be number one. I also have, usually genies give like 3 wishes, right? There is definitely something else that we are working on at the moment, and this has all been inspired really by COVID-19 and perhaps the positive impact of social media. I moved to Bangladesh about 5 years ago. And when I, talk to people about my work, about microbiology, I always, of course, most of the public do not have a lot of interest in microbiology, or I am a genomicist by training. But what COVID really did is exposed entire country to microbiology, to virology, to science, and the immense interest that I am seeing specifically in young girls is phenomenal, something that we have never experienced as a country. Because my team was involved in genomic sequencing, even if I go to a coffee shop, chances are someone is going to come up to me, usually a girl, and say, I want to learn how to sequence. I want to become a scientist. And this is something very personal to me. And if I had all the money, I would leverage this interest, this momentum, and use it to train the youngest generation, focusing on girls, to become scientists. So we are actually starting it slowly. We are building a research institute with the support of the government. We just got a piece of land where it will be a research institute for specifically young scientists, and there will be a training program where we'll bring in girls specifically from rural region who can come, stay, get trained, just have exposure to science. So yeah, those are, I think, 2 wishes. I want to build a training program for all girls in Bangladesh and just tell them, look, you can become a scientist. So yeah, those are 2 things I can think of now.
Thank you, Shaha. It seems like it's a good campaign, running for office anytime soon, eh? Dr. Blas, what about you? What would your wish?
I like the last wish that Sanjiti has. However, I have to ask my own wish, right? so my own wish currently will be to make sustainable our program. No? And funders do not give you money for that. No? They provide you funding for implementing and measuring the program, but that's it. They don't give you funding for sustainability, and sustainability is a very long journey, because you have to work on a top-down approach, which is kind of what we're doing. We're talking with the Regional Health Direction of Loreto, the Regional Government of Loreto, Ministry of Health of Loreto. It's so hard. I mean, if you read politics in Peru, you will be surprised. However, you also have to work with the community, no? Organizing the community maybe to advocate for the inclusion of community health workers in the Peruvian health system. That is a long journey. It needs funding. And I think community health workers are super important to be part as the formal health system in Peru. And they can solve not only maternal and newborn health like we're doing, but also other problems, violence, dengue, malaria. So I think the insertion of the community health workers in the Peruvian health system is key. And I will ask funding for that.
Thank you, Dr. Blas. It's been a fantastic hour plus with the 2 of you. I'm amazed at the amount of work you folks have already done. I'm excited for what the future holds, looking forward to fantastic work from you. I'm energized. I want to join your programs right now. On behalf of the Center for Global Health and Social Responsibility at the University of Minnesota, on behalf of Dr. Phil Peterson and Dr. Paul Kui, my thanks to you for not just the work you do, but also being part of this amazing presentation. I want to especially thank Dr. Paul Kui and Dr. Phil Peterson for all their support over the years to the University of Minnesota and to our center. As longstanding leaders within our global health community and as founders of our center, they have built this platform we're now using to strengthen the University of Minnesota's ties with partners around the world. This, like I mentioned, is the 5th year we're holding this lecture. Please go to our website, globalhealthcenter.umn.edu, to see all our other activities. And then I have 2 quick asks for you. Number 1, we'll send out a survey, and I would request you to please fill it up, because we really want to know what you want us to do next in our QP lecture and other ones. And also, please consider supporting the work of our center with a gift to the QP Fund. If you're interested, please contact us for not just activities like this, but our other activities too. Again, thank you everyone for joining us today. Thank you for my fantastic team at the center. Special thanks to Anna Pendleton, Shannon Benson, and Katie Griffin for the behind-the-scenes work in running this. Bye now.
Bye, thank you.